if you were bleeding internally, I mean, the absolute last thing you'd probably think to do is inject yourself with pure adrenaline.
Right. Yeah. It sounds a lot like throwing gasoline on a fire.
Exactly. Because we usually think of adrenaline or, epinephrine as this ultimate full-body biological lightning bolt.
Yeah, for sure.
You picture an EpiPen saving someone from a severe peanut allergy or like a frantic emergency room scene. It's always framed as a blunt instrument.
It's like a total system override.
Yeah, exactly. But welcome to the deep dive. Today we're taking a look at some fascinating source material that just completely flips that whole image on its head.
It really does. Because we are exploring a space where this sledgehammer of a drug is used with just microscopic precision.
Right. And to establish our foundation right away, today's exploration is based entirely on a highly detailed medical lecture video. It's titled HCC 1475-23 Epinephrine Injection, and it was uploaded by Gautamukala S. Raju.
It's a fantastic resource.
It really is. And our mission today is to understand how gastroenterologists are taking this famous chemical and using it in incredibly precise, hyper-targeted ways deep inside the human gut.
They are essentially using it as a chemical tourniquet.
Which is wild. And for you listening, while you might think of epinephrine strictly as, emergency medicine, exploring this material reveals the hidden plumbing and mechanical engineering of your own internal ecosystem.
It's all about the mechanics.
Okay, let's unpack this, because you can't just take a raw syringe of adrenaline and squirt it into someone's stomach lining, right?
No, definitely not.
There has to be a specific calibration process before this chemical even gets near a patient.
Yeah, and dilution is the absolute key to everything we are talking about today.
Okay.
Before a doctor can use this tool, they have to manipulate its concentration to match the specific anatomical goal.
So they have to water it down.
Basically, yes. The exact ratio of epinephrine to saline completely dictates what happens to the tissue. So whether you are trying to stop a massive active bleed, or if you are simply preparing an area for a delicate surgical procedure, the recipe changes.
So what are the baseline numbers we're looking at here? Like, what's the starting point?
Well, a standard off-the-shelf vial of epinephrine comes in a 1 to 1,000 concentration.
Okay.
And that translates to 1 milligram of the drug per milliliter of fluid.
Which is pretty strong, right?
It is incredibly potent, yes.
So if a doctor is staring down an active bleed in the stomach, they don't just draw that up and use it.
Oh, doing that would cause severe localized tissue damage.
Oh, wow.
For active bleeding, achieving what we call hemostasis. They actually dilute that base material down by a factor of 10.
So that makes it...
That creates a 1 to 10,000 solution.
1 to 10,000, got it.
Yeah, and that is the standard battlefield concentration for stopping a bleed.
Right.
But the fascinating part is how drastically that changes if the doctor is doing preventative work instead.
Wait, what kind of preventative work? Like preventing a bleed before it happens?
Exactly. So imagine a patient has a large, flat, precancerous lesion growing flush against the colon wall.
Okay.
The doctor needs to shave that lesion off without cutting too deep and, perforating the colon.
Which sounds terrifying.
It's a delicate process.
Yeah.
So to do that safely, they perform procedures with highly technical names, like endoscopic mucosal resection or EMR, but functionally, they are just injecting fluid underneath the lesion to lift it up.
To create like a buffer.
Exactly. A safe fluid cushion to cut against. And for this, they dilute the epinephrine massively.
Oh, massively.
They might inject that original drug into a 100 cc bag of normal saline. That brings the concentration to 1 to 100,000, or sometimes even 1 to 200,000.
I was trying to wrap my head around that scale when I was looking at the source. It's almost like hot sauce.
Hot sauce.
Yeah, think about it. That 1 to 1,000 vial is like dropping pure, ghost pepper extract directly onto your tongue.
Right. You get an immediate, overwhelming reaction.
Exactly. It's painful. But taking that down to 1 to 100,000 for a preventative cushion, that's like taking a single drop of that hot sauce and mixing it into a giant industrial-sized pot of chili.
That's actually a great way to visualize it.
You get this really mild structural effect instead of a localized fire. But I have to ask, why do they need even a trace amount of epinephrine just to lift the tissue? Like, is the gut really that sensitive? Why not just use plain water or saline?
What's fascinating here is the physiological nuance of the mucosal layers.
Okay.
When you are lifting that tissue to shave off a lesion, you know you're going to be cutting tiny blood vessels. It's unavoidable.
Right.
So you want to preemptively shrink those vessels, a process called vasoconstriction. and you want to do it just enough to keep the surgical field clear of blood.
Oh, I see.
However, you don't want to clamp them shut so aggressively that you completely starve the healthy surrounding tissue of its oxygen supply.
Because then the tissue dies.
Exactly. So that extreme dilution creates a really delicate, sustained balance.
Okay, so the dilution is the calibration.
Yes. But, I mean, a perfectly mixed bag of fluid doesn't do any good if you can't actually get it to the target.
That is the real challenge.
And the target here is hidden behind several feet of twisting, turning human intestines.
Right. And this is where the delivery system comes in, and where that mechanical engineering aspect we talked about really shines.
Because they're using scopes, right?
Yeah, the doctor is operating through an endoscope, which is a long, flexible tube. And to deliver the drug, they have to pass a secondary microscopic tube and injection catheter all the way down the working channel of that scope.
And I noticed in the lecture there are different types of these catheters.
There are.
Like, the standard plastic ones make sense for regular situations, I guess. But there is a huge emphasis on catheters that have a metal outer sheath.
Yes, the metal sheath is crucial.
Why would you need metal inside a flexible tube? Doesn't that defeat the purpose of it being flexible?
Well, you have to remember that the colon is rarely a straight line.
Right, it's all coiled up. It has sharp bends and overlapping loops. In gastroenterology, a highly twisted intestine is referred to as tortuous.
Tortuous. Sounds painful.
It's certainly difficult to navigate. So pushing a flimsy plastic catheter through an endoscope that is navigating a tortuous colon, it's like trying to push a wet noodle through a garden hose that's tied in a knot.
Oh, wow. So the plastic just kinks and bends inside the tube.
Exactly. It just jams up. The metal outer sheath provides the necessary rigidity to navigate those hairpin turns so the needle can actually deploy cleanly at the final destination.
That stiffness is also required for some of the more acrobatic maneuvers, right?
Acrobatic maneuvers.
Yeah, like trying to inject something at the very top of the stomach. The source mentioned that was really tricky.
Oh, yes. Reaching the fundus, which is the ceiling of the stomach, that requires a maneuver called retroflexion.
Retroflexion.
Yeah, the doctor basically drives the scope into the stomach, then bends the tip entirely backward to look up at itself.
That is insane.
It is. And deploying a needle through a tube that is bent in a tight U-turn requires serious mechanical support.
So the metal sheath stops it from buckling.
Precisely. That metal sheath is also mandatory when working in the incredibly tight, intricate spaces of the bile and pancreatic ducts, during an ERCP where precision is measured in millimeters.
Okay, so you have your targeted dilution, and you've navigated this metal sheath catheter through all these twists and turns.
Yep.
But then there is this massive warning in the lecture about the moment right before injection.
The priming.
Yes. The catheter must be primed to remove all bubbles. The instructor was incredibly adamant about this. He said injecting an air bubble is catastrophic to the procedure.
It is a golden rule.
But why? Why is a tiny bit of air such a big deal in the gut?
It actually comes down to basic physics.
Physics.
Yeah, so the endoscope might be 3 or 4 feet long, and the fluid needs to travel from the syringe in the doctor's hand down that entire length and out the needle into the tissue.
Okay, that makes sense.
Well, fluid does not compress, air does.
Oh.
If there is a pocket of air anywhere in that long, tiny tube, the mechanical force changes entirely.
I see it now. It's exactly like bleeding the brakes on a car.
Oh, that's a perfect analogy.
Yeah, because in a car, the brake lines are hydraulic. When you step on the pedal, the fluid transfers the force directly to the brake pads.
Right.
But if there's air in the line, that air just squishes. You step on the pedal, the pressure fails, and the car doesn't stop.
That is exactly what happens here. When the medical assistant pushes the plunger on the syringe, if they hit an air bubble, the force is just absorbed by the compressing air.
So the drug just dribbles out.
Or it doesn't come out at all with the right pressure. Or it delays by a crucial second. And in an active, high-pressure bleeding situation, a loss of hydraulic pressure means the drug fails to penetrate the dense tissue.
Wow. It really is just advanced plumbing and hydraulics.
It truly is.
All right, so the tool is perfectly calibrated, the line is primed, absolutely no bubbles. Let's move to the actual tissue, the battlefield.
The battlefield, yes.
What happens mechanically when this chemical hits a severe active bleed, like a peptic ulcer?
So peptic ulcers usually involve an exposed, actively pumping blood vessel in the stomach or the intestine.
Like a tiny geyser.
Exactly. So the doctor aims at 1 to 10,000 dilution right at the base of the vessel, and the chemical immediately triggers vasospasm.
Vasospasm.
Yes. The muscles in the blood vessel wall violently cramp and clamp shut, It physically strangles the bleed.
Now, the standard dose mentioned for this is about 5 to 10 milliliters.
That used to be the standard, yes.
Right. But there was a fascinating detail in the source about how much fluid they actually use now.
Yeah, medical techniques are always evolving based on clinical observation. And a highly influential group of researchers, they're frequently cited in the literature as the Oriental Group, they conducted studies demonstrating that a significantly larger volume is actually better.
How much larger?
Injecting between 13 to 20 milliliters proved vastly more effective at controlling the initial hemorrhage and, crucially, preventing it from restarting.
Wait, why does more fluid help so much? Is it because more fluid creates more physical pressure in the surrounding tissue?
Yes, exactly.
Like an internal thumb pressing down on the wound?
Precisely. You get the chemical clamping from the drug itself, plus the mechanical compression for the sheer volume of fluid cooled in the tissue around the vessel.
That is so smart.
It's very effective. But there's a critical limitation to this approach.
It's not a permanent fix, is it?
No.
It's just a pause button.
Exactly. The drug metabolizes.
Yeah.
The vasospasm inevitably relaxes. If the doctor just injects the epinephrine and walks away, that vessel will absolutely start bleeding again within hours.
So the chemical tourniquet basically buys you the time to clear the field,
Yes,
but then you have to actually fix the pipe,
exactly. They must always follow it up with thermal cautery.
like a heater probe.
A heater probe, a gold probe, or a bipolar probe. They use it to literally weld the vessel shut permanently.
Wow.
The chemical injection provides a dry, visible field, so the thermal tools can actually do their job safely without just boiling a pool of blood.
Makes total sense.
Now, contrast that immediate clamping action with how they treat something entirely different, like large pedunculated polyps.
Pedunculated polyps. Okay, those are the growths that look like a mushroom, right?
They are, yes.
With a thick stalk and a bulbous head.
And the larger ones have massive high-pressure blood vessels running right up the center of the stalk to feed the head.
So if a doctor just loops a wire around it and chops it off...
The stalk will bleed heavily.
Right.
To prevent this, they inject that stalk and the head with several milliliters of epinephrine.
But wait, the goal isn't just to clamp the vessel here, is it? Because the source specifically describes this as causing epinephrine volume reduction.
Yes.
How does injecting fluid physically deflate or shrink the tissue?
The mechanism is a bit different here. The vasospasm clamps off the arterial blood supply feeding the polyp. And by temporarily starving the entire structure of its blood volume, the polyp loses its internal pressure.
Oh.
It physically shrinks and deflates, making the stalk much thinner and significantly safer to cut through.
And this leads to my absolute favorite detail from the entire source material.
Let me guess.
The walkabout technique.
It is wonderfully practical medicine.
It really is. So imagine a massive polyp in the sigmoid colon, which is down near the end of the digestive tract.
Right.
It's so big, it's practically blocking the entire tube. The doctor injects the stalk with epinephrine, but that volume reduction takes time, right?
Yes, the polyp doesn't just instantly deflate.
So instead of just staring at it, they literally drive the endoscope past the polyp, all the way up to the cecum, to the very beginning of the large intestine, and just casually complete the rest of their exam.
They take a walkabout.
They take a walkabout.
They are maximizing their efficiency while the pharmacology does the heavy lifting.
That is so cool.
By the time they finish inspecting the upper colon and pull the scope back down to the sigmoid, the epinephrine has had, 10 or 15 minutes to act.
And the polyp.
The massive polyp is now a fraction of its size. The vessels are constricted, and it can be removed safely.
It's just such a great image of calm, calculated medicine. Like, I've injected it, I'm going to go look at the rest of the colon, I'll be back when it's smaller.
It's very elegant. And it's also highly useful for post-polypectomy bleeding.
But see, massive polyps and geyser-like ulcers, those are obvious targets.
True.
What really surprised me was how they handle bleeding that hides, like in tiny microscopic places, because that requires a completely different tactical approach.
Oh, absolutely. Finding the source of a subtle bleed in a colon full of twisting folds is incredibly difficult.
I can imagine.
Take diverticular bleeding, for example. Diverticular are these small, bulging pouches that can form outward from the lining of your digestive system.
Like tiny little pockets.
Exactly, like pockets. And they can bleed either at the dome or the neck of the pouch.
And if one of those pockets starts bleeding, you have to find it first.
Yes.
But the instructor stressed an absolute golden rule before any actual treatment begins.
The tattoo trick.
The tattoo trick.
Yes. Because you have to remember, the colon is a dynamic, living organ. It undergoes constant muscular contraction waves to move contents along.
So if a wave hits and your endoscope gets pushed back or you lose your angle,
You've lost the bleeding pouch.
it's just gone among dozens of identical non-bleeding pouches.
It becomes a complete mess. You might never find it again.
Wow.
So to prevent this, once the exact bleeding diverticulum is identified, the doctor injects a specialized permanent medical dye into the tissue right next to it.
Oh, it's exactly like dropping a GPS pin on your phone right before you drive into a canyon where you know you're going to lose cell service.
That's a really good way to put it.
Yeah. If you get turned around, that visual marker guarantees you can navigate right back to the exact millimeter you need to treat.
Maintaining orientation is half the battle in these procedures.
I bet.
But perhaps the most elegant use of epinephrine in this entire hide-and-seek category is how they handle angioectasias.
Specifically in the cecum, right, the right side of the colon.
Yes.
Now, angioectasias are those abnormal, fragile spider webs of tiny blood vessels just under the surface, correct?
They are. They are very superficial and spread out. And because they are so thin, they tend to just ooze blood.
Okay.
The instinct for many practitioners is to just go in and immediately blast the whole web of vessels with heat to stop the oozing.
But the source warns heavily against that.
It does.
Because the right side of the colon has a much thinner wall than the left side. If you just start burning that spider web blindly, you risk something called a delayed post-polypectomy syndrome, or worse, a delayed perforation.
Exactly. And a perforation means burning a hole entirely through the wall of the intestine.
Which allows gut contents to spill into the abdominal cavity.
Yes. It is a catastrophic, life-threatening complication.
Yeah.
The thermal energy from cautery tools like APC, argon plasma coagulation, which is essentially a contactless, laser-like beam of ionized gas, that energy can penetrate much deeper than intended.
So to avoid burning the whole area and causing a perforation, they use the epinephrine trick first.
Yes, they do.
They inject the diluted adrenaline into the area, and the result is visually striking.
It really is.
The surrounding normal capillary beds undergo rapid vasoconstriction. They clamp down and practically turn white.
The tissue pales out completely.
Mm-hmm.
And because the healthy tissue turns white, it isolates and exposes the single abnormal feeding vessel that is actually supplying blood to that entire fragile spider web.
Oh, I see. It's like turning off every single street light and house light in an entire neighborhood just so you can easily spot the one house that is illegally running a massive glowing generator.
If we connect this to the bigger picture, this is just diagnostic brilliance.
Yeah, it's so clever.
They are not just using the drug as a treatment to stop the bleeding. They are utilizing its physiological side effect, the paling of the tissue, as a chemical flashlight.
A chemical flashlight, wow.
It maps the microanatomy in real time. Once that single feeding vessel is illuminated, the doctor only needs to target that one specific spot with their APC, or cautery beam.
And then they just reinforce the thin wall with a mechanical clip?
Exactly. It minimizes the thermal damage completely.
It's incredible. But, and there is always but in medicine, we really need to take a step back here.
Okay.
Because we've been talking about this like it's purely plumbing. You know, calibrating mixtures, bleeding hydraulic lines, welding pipes.
Right.
But this is happening inside a living patient. You are still pumping raw adrenaline into a human being.
You are.
There has to be a systemic ripple effect, right?
Absolutely. The gut is highly vascularized, meaning it has a massive blood supply.
Okay.
When you inject epinephrine locally into the stomach wall or the colon, a certain percentage of that drug inevitably absorbs into the patient's main bloodstream.
And epinephrine is a potent cardiovascular stimulant. So while you are fixing the plumbing in the gut, you are simultaneously hitting the heart with a stimulant.
Exactly. And the complications outlined in the lecture primarily involve irregular heartbeats, arrhythmias, and sharp, sudden spikes in blood pressure.
Hypertension.
Yes, which is an expected physiological response to adrenaline.
Right.
However, there is a highly specific, severe risk mentioned that perfectly illustrates the danger of too much localized vasoconstriction.
What's that?
In older patients who suffer from severe atherosclerotic vascular disease, meaning their arteries are already narrowed, stiffened, and blocked by plaque injecting too much epinephrine locally, can accidentally precipitate bowel ischemia.
Bowel ischemia. That means restricting the essential blood flow to the tissue for so long that the tissue actually starts to die.
Right. By artificially clamping the blood vessels shut so tightly in an area where the vascular system is already compromised by disease, the blood cannot find alternate routes to bypass the clamp.
So you're essentially suffocating a section of the intestine.
Yes, suffocating it completely.
Think about that for a second. We've all had that moment where, I don't know, someone jumps out and scares you, or you narrowly avoid a car accident, and your heart just pounds out of your chest.
Oh yeah, the rush.
Your whole body feels wired. Now imagine taking that exact chemical trigger, concentrating it, and injecting it directly into an organ whose arteries are already struggling to stay open.
It's a huge risk.
So, by trying to put out a small, localized fire in the gut, doctors have to be incredibly careful they don't accidentally start a massive electrical fire in the heart or completely choke off the blood supply to the organ they are actually trying to save.
It is a profound high-wire act. The physician must balance the immediate life-saving need to stop a hemorrhage against the systemic, invisible risks to the patient's entire vascular system.
So what does this all mean when we zoom out and look at all these techniques, these extreme dilutions, and these systemic risks?
Well, it means that epinephrine is an astonishingly versatile tool, but it is not magic on its own. It can be a 1 to 10,000 lifesaver for a bleeding peptic ulcer, or a 1 to 100,000 preventative fluid cushion for a delicate polyp resection.
Depending on the dilution?
Exactly. But its true power is only unlocked when paired with precise physical tools.
The metal sheath catheters, the mechanical clips, the thermal gas beams.
And most importantly, human ingenuity.
Yeah.
Techniques like dropping the tattoo pin or taking a walkabout to let the chemistry work. It is the ultimate marriage of pharmacology and mechanical engineering.
I think that sums it up perfectly. And for you listening, the takeaway here is that the next time you hear about a friend getting a routine colonoscopy or a family member getting an endoscopy to check on a stubborn ulcer, I want you to picture this incredible, high-stakes, microscopic surgery happening inside them.
It's happening every day.
Doctors navigating tortuous twists of intestine, bleeding hydraulic lines, dropping permanent GPS markers, and literally controlling the physical size of blood vessels on command with a chemical tourniquet.
This raises an important question, though, doesn't it?
What's that?
If doctors can achieve these massive physical changes in our gut with fractions of a milligram, what is happening in our bodies naturally every single day?
Oh, it absolutely does. And this is exactly the thought I want to leave you with today. We just spent this entire deep dive looking at how gastroenterologists artificially induce targeted vasospasms and volume reduction using tiny, highly diluted amounts of injected epinephrine.
Right.
But your body manufactures and releases this exact same chemical naturally.
Constantly.
So how do our own natural adrenaline spikes like when we get stressed at a toxic job or get cut off in heavy traffic or experience a sudden fight or flight panic? How do those natural chemical dumps subtly alter the internal blood flow, the digestion, and the mechanical plumbing in our deep organs without us ever even realizing it?
That's a wild thought.
If a fraction of a milliliter can physically deflate a massive polyp and pale out an entire capillary bed, what is a chronic state of stress doing to your internal ecosystem? Something to mull over. Thanks for joining us, and keep exploring the hidden mechanics of your own bodies.